Okay, good afternoon, everyone. Welcome to this short webinar. We'll be discussing options for bridging the resource gaps in the NHS to deliver digital enablers. I'll be posing some questions to the panel and inviting them to share their thoughts and experiences in this area. So let's start with some introductions. The session is arranged by AI Digital and 1010. I'm Phil Haynes. I'm part of the AI Digital team. I'll be chairing the session. My background is originally automotive manufacturing before spending the last 18 years focusing on health and care. I'm passionate about process improvement and also human factors of change. So a bit of background on the organisations themselves. We have AI Digital, which is a dedicated service transformation and project delivery provider using project change and technical expertise to help public and private sector organisations tackle difficult and complex projects where outcomes really matter. 1010 is a technology consulting company providing consulting solutions for quality engineering, automation and business analysis. They deliver solutions tailored specifically for you to help improve software quality, accelerate delivery and enhance operational efficiency. In addition, their 1010 Academy hires, trains and deploys junior engineers to help clients meet their technology skill set gaps and provide long-term solutions for growing their own tech team. For those organisations, in terms of our panellists, from AI Digital, we have Karen Sandy. Karen has over 30 years experience in industry and the NHS, delivering programs and projects on behalf of commissioning and provider organisations. Karen believes passionately in the value of digital technology as a clinical enabler and the voice of the patient or service user in project delivery. From 1010, we have Nick Huell. Nick is a principal consultant with 1010 with over 23 years in software testing and technology delivery, and spent 11 years working on national NHS IT through NPFit to NHS Digital on systems such as Spine, Spine2, Choose and Book and e-prescriptions. Nick has experience across both public and private sectors, is currently working as a programme test manager on a large project within central government. As an independent member of the panel, we also have Jane Birch-Jones. Jane has a nursing background and has several decades of experience in projects, change management, benefits realisation in health and care settings. Most recently, Jane worked as programme manager for public-facing digital services in Nottinghamshire, where key deliverables included online consultations, remote monitoring and digital inclusion. Jane has published several articles and is the co-author of Digital Healthcare, the Essential Guide. So that's our expert panel. I'm looking forward to hearing their thoughts and experiences as I pose some questions. First question, how can we support you with the digital aspects of the priorities and planning guidance from 2021-22? That's the first question that I'd be interested in thoughts from you all. Nick, I'll come to you first. Would you like to just share from a 1010 and personal perspective on that, please?
Thank you, Phil. Thank you for the introduction. Welcome. Good afternoon, everybody. So, 1010, we have our own tried and trusted methodology. We call it Tenology, and it takes customers through a process of discovering, defining, planning, preparing, delivering, refining, sustaining and informing. That's a bit of a mouthful, but it is a life cycle, and we use across all our different delivery capabilities, and I'll touch a little bit on these through the webinar. There are quite a few ways in which 1010 can assist an ICS with the digital aspects of priorities and planning requirements. A very basic example will be using our growing business analysis practice to help with detailed design requirements capturing, requirements elaboration, and helping drive towards user-centered design with accessibility concerns, etc., at the heart of patient-facing systems. As many business analysts will do, they work in liaison amongst the ICS business and technical stakeholders in order to understand your structure, your policies, your operations and IT systems of your organisations. Diving a bit deeper into the priorities and planning requirements within the sort of infrastructure area, there's many ways 1010 can assist with the technical testing, the functional and system integration testing, looking where we can to automate, so we improve the speed of regression testing. Specific examples will be where we can add value around the validation of cloud-based services, for example, including complex data migration tasks from legacy systems and the decommissioning of legacy services. And incidentally, that's part of what I'm doing in my central government project at the moment, just to highlight the fact that it's something that we have experience in. 1010 also has a wide range of mobile devices that can be used to test compatibility of ICS systems across a range of different devices, operating systems, etc. I think that's probably could be of great interest when supporting testing of digital innovation for self-care, prehab, post-operative support and consultation, for example. Things that will enable digital innovation. Where shared care records are coming in, that's going to be an interesting implementation across an ICS ecosystem. So 1010 can assist in the integration and test and assurance, demonstrate that data flows seamlessly where it needs to, and can be there when it's needed for patient support and supporting care as patients move through different care settings. Related to that is also this movement of staff between different areas of ICS, making sure that their credentials work so that staff can work flexibly across different systems in different care settings. All that sort of leads into, to some degree, system and information security. And this is another area where we can provide value support. We have experience in demonstrating that data is secure, so that if going back to functional tests of security, that, valid credentials and correct user groups, that sort of thing. It's very basic, but it's imperative that those things work. And then at the back end of the system, operation acceptance testing, where we look at the backup and restores of systems and data, that the alerts and monitoring of the system and infrastructure health to make sure that your systems are highly available where they're needed. So when a patient or a clinician is trying to provide the care, to the patient, their information is there for them. Adding on further things like checking antivirus scans and threats and vulnerabilities, and making sure that server resilience and failover is all as it should be and roughly aligned to the what good looks like. Success measure number 3, which I think is safe practice, if I've remembered my areas on that. We should also touch very briefly on performance testing. I personally have a lot of experience in this area. It's one of our core services and has been for many years. I think it's a great benefit to demonstrate that systems and services are scalable as users increase, because if you've got different users from different areas of ICS, it may well be that a system that was scoped for 1,000 users now needs to have 1,500 users logged in, because different areas of ICS need to share information. We would want to adopt an integrated approach and build performance into products where new products are being deployed. So it's you get much greater trust from your end users, and you're minimising reputational risks. The last thing to mention is accessibility testing. This is a really important one for from a patient point of view from websites. We all understand that the Equality Act back in 2010 brought into something called in inverted commas reasonable adjustments, if I remember rightly, but really that's the WCAG AA standard for most people. And it's just that websites and services don't exclude or make it difficult for either visually impaired or those that use screen readers, autistic users, deaf and hard of hearing users, etc. So there's lots of ways we can help, and we're keen to lend our expertise to the health sector. Karen, have you anything to add yourself there?
Yes, I suppose just really starting now to pick up on what you said about health inequalities. I think we know that during the pandemic, health inequalities have really exacerbated for many people across physical and mental health conditions, but particularly, and this is one of the areas where I think is really important to think about too, in relation to the planning guidance, which is actually for 22-23, where we're beyond that. And one of the key areas around the planning guidance for 22-23 is improving health inequalities for those with learning disabilities, those living with learning disabilities and autism, and that is a sort of a key priority. Now, we know too that there are many innovative trusts across the country, and Jonathan, I'm aware that you're part of that innovation in Hertfordshire, where remote monitoring, not remote monitoring rather, but digital resources have been used to support greater integration of care. That means mental and physical health care being monitored at the same time. And we've been part of this work in Hertfordshire, and we've certainly seen that it's it's delivered some really interesting outcomes in relation to the overall number of people that have had, you know, an integrated physical and mental health care plan, but equally those that have been identified with out of parameter readings for GP follow-up. So I think there are some really opportunities to scale that up across systems and to take the learnings from the really innovative organizations that are already doing this. But equally, you know, there's an opportunity to really to extend and look at, you know, how we make digital technologies more available in mental health services. For example, we've got lots of examples, which I'm sure Jane will come on to shortly, about, you know, resources that have happened within physical health services. But, you know, there's lots of opportunity to really scale up in mental health services. And, you know, I know that, you know, Hertfordshire, for example, is a really good example, a place of really good practice. But there's more we can do. There's more we can do, and you know, this is part of what AI Digital can offer. We don't have a conflict of interest with any particular digital tool. We can work with those that are provided, and it's the support and the short-term support to deliver that we can help with. Jane, I'm sure you've mentioned you've probably got lots of case studies around things that have happened in Nottinghamshire. So I'm sure our audience would love to hear about some of those things that have happened and what the outcomes have been for patients, really.
Yeah. So as you say, working across an ICS, I was a public-facing digital services program manager, and I can share with people the development of a citizens-facing digital services strategy, which was led and co-designed by citizens and staff. And this ultimately resulted in us procuring a patient digitally held record, which was one of the first systems to be integrated through the NHS app, because through all our work with patients in designing that strategy, developing that strategy, the one thing they said was they wanted everything to do with their health and care in one place, single sign-on, and it's been great that we've been able to deliver that for them. Aside that, one of the very important things that we were really keen to do was a digital inclusion blueprint, and we based that on some local digital inequality research. So everything that we've done is based around what our local population requirements are, both in terms of whether they can cope with digital, whether they've got access to it, but also taking account of health inequalities as well. So we've been able to place projects in places where people are digitally excluded and support them and help them to access digital services. One of the projects that we delivered was a two-tier remote monitoring solution across the ICS, and that again took account of digital inequalities. So there was one system that all you needed was a mobile phone, and you didn't even need a very basic mobile phone. You didn't even need any credit on it. But then we've got another system that is you don't need a smartphone or a laptop, and that has more functionality, but is available to people who have got better digital skills. So we wanted to make sure remote monitoring per se was available to all our population, but we did it in two tiers so that we could meet everybody's requirements. We all still on the remote monitoring during COVID. We were able to implement remote monitoring for COVID virtual wards in just 5 days, worked really well with the supplier, and they were really helpful in helping us with the testing, etc. And the service were absolutely thrilled, as were the patients, that we were able to set this service up in 5 days, and that continues to be utilised and has been spread to other virtual ward through the ICS.
Jane, just a question: do you feel that some of these digital advances have become business as usual. Maybe this is for all of you. So a lot of people in the system reacted very quickly through the COVID period, through necessity. Do you think a lot of these initiatives and that innovative thinking and that introduction at pace of digital enablers, has it become business as usual now? So is it Karen's point almost that spread and adoption now? That...
So the virtual ward stuff and the remote monitoring, certainly. Another area where we set up a service really quickly was for women with postnatal women who had got high blood pressure, and of course they didn't want to keep bringing them into hospital, so we were able to set up a service for them to do their own remote monitoring. One of the projects which I think was brilliant but has lost some urgency, or seems to have lost some urgency, was we delivered GP virtual ward rounds in care homes using virtual vital signs monitoring equipment, and that was able to provide more timely care for residents, because the GPs would put aside time every day to do these virtual ward rounds, and it was usually in the morning, and it meant that very quickly any outcomes from those that virtual ward round got actioned really quickly, instead of having to wait till the afternoon when the GP usually did his or her visits. And we've seen some really significant savings in terms of GP time, and also less disruption in the care home routines, because GP used to arrive and the staff used to have to abandon whatever they were doing to support the GP. The take up of that was good in some areas, but trying to engage with the care homes, going through what they were going through, was slow. The GPs were really keen, and some of the specialist nurses as well. But we have seen that we've tried to continue that, because we feel that the outcomes are really good, but the care homes have really struggled to engage with us. But we would keep going with that. Yeah.
It's not because it's not just changing practice, it's culture, isn't it, as well? And
exactly. And one of the problems we had in the care homes was the fast turnover of staff and having to go back and retrain the staff. So we addressed that by trying to have super users, which worked quite well.
Karen, do you want to? Sorry, Jane, just bring Karen in there.
I was just going to add to that and just say, yes, that one of the lessons learned in all of this is that there's been a rapid take up of digital technology during the pandemic, quite rightly so, and it's been a real opportunity across the NHS. But actually, what that does bring with us is the cultural element, and where you have clinicians who are have a practice of how they deliver their care. Bringing something new into it does require more engagement and more work to support that cultural change. And we have seen, for example, we can compare where there's been sort of really active work around that. We can see the benefits that whole engagement and that user-centered design almost has worked to create those outcomes more quickly. But it is about that cultural change and how we take that into business as usual. And we can see what we need to bring into future projects to make that spread and adoption happen at a faster pace.
Yeah, I completely agree. Thanks, Karen. Okay, I just might take us on to the second question, if that's all right.
Phil, before we do, can I just say a little bit more about the digitally held patient record, because there's some quite significant opportunities for self-care of patients, and obviously increasing compliance and reducing staff time. So the system that we integrated with the NHS app meant that, as well as all the NHS app functionality, patients are able to contribute to their own health and care data, and that will include proxy access, which is really important for obviously ensuring that as many people as possible can access it, including children and people with special needs, etc., and people with dementia, because that's something that I've experienced with my mum. This additional functionality means that people can self-service pathways such as patient-initiated follow-up, self-triage, referral and condition management, and access, advice and guidance. They've also got access to their care plans, and they can develop their own care plans, or it could be care plans with professionals, access to the test results, medications, history, correspondence, and appointment management. Also, obviously, the remote monitoring side of it, and also online consultations has been a really positive thing in terms of accessing GPs, and also some secure messaging functionality. And there's some really good outcomes in terms of patients being able to request sick notes via online consultation, request things like, oh, I've got a mole. They can send a picture of it, and then it can be triaged at the surgery, and the GP gets back to them whether they need a face-to-face. And also the other thing about all that functionality is the patient choice and sustainability of their care, and also it really promotes we've really seen an increase in self-care and compliance.
Yeah, which is a key point, isn't it? Given the demands on the system, you know, in terms of waiting times, it is that trying to enable people to be able to help themselves as much as possible.
Yes, exactly.
Be there for them when they need us.
Yeah.
Okay, so if I just focus on question 2 then. So how can we support ICSs with their annual digital maturity, what good looks like, assessment framework, and help with improvement plans? I feel that some of what we've talked about already touches on that in terms of having expert resource that can be drawn in as necessary. So maybe we'll focus on the second part of that, helping with improvement plans. And Karen, I might come to you in the first instance, and then Nick, your thoughts as well. So I'm just going to encourage a couple of sentences from you.
Yeah, so I've got one sentence and an example really to share. And what we can do is to be your critical friend, and I think that's a key piece in terms of what good looks like. The example I would give is that we worked with an acute trust who were upgrading their EPR, and previously when they'd done that, they'd experienced some performance issues. So what they asked us to do, and we did this over a 6-week period. We assessed the sort of critical areas, guided by them, and we delivered a dashboard of areas for high priority improvement, together with short, medium, and long term recommendations for actions moving forward. So we're not talking about stuff that can take 6 months, a year to complete. We can actually do a short, sharp assessment of what needs to be in place to make sure that change happens.
Nick, thoughts, please?
Yeah, the critical friend part is quite interesting, what Karen has said, because that's often the role of a tester in a delivery project. This isn't quite right, or it could be improved if, or are you sure you want to do it this way? And all those things are all sort of valid. Some of these, it's not always black and white. We talked before that the call went live about perfect sometimes being the enemy of good. But you've sometimes got to work out, well, where is good enough? And with improvement plans, you may have that, we want to take a step-by-step approach, and 1010 can help with that. We've mentioned, sort of synergies for simplification of infrastructure. That's certainly mentioned in Measure 2 for ensure smart foundations on what good looks like. And absolutely, we can help in the testing and the analysis that those are the right things for organisations to do. And implementing a shared care record is an enormous integration piece of work, if not a brand new design start from the beginning piece of work. So again, there's lots that we can be involved with, and where we can help individual ICS organisations improve and hit their targets.
Okay, thanks, Nick. Thanks, Karen. Question 3, Jane, I'm going to direct to you. Really, we know the challenge with plan care waiting times that the system faces. How do you think, or what's the opportunity in terms of some of the examples you've shared with us? How do we support the spread and adoption of those, the amplification of some of those changes that have been done on the local level within a system? But obviously, we know there are 42 across the country. So, what's your view on how how we could support as organisations, AI Digital and 1010, how can we support ICSs to utilise those digital enablers to contribute to that focus on planned care waiting times?
Well, I think if I can start with some examples of how we've utilised digital enablers, I think that would be useful. But also to say, my experience is sometimes in terms of the change management, we've had probably as much, if not more, success in pushing the use of digital enablers with patient groups and giving them the knowledge of this is what's available to you. If you want to use it, talk to your clinician, rather than us as, if you like, IT people and transformation people going to the clinicians and saying, oh, we've got this functionality, we think this is how you could use it. Obviously, mostly they are interested, but there's the time factor. But we've found that it's been really helpful when we've sort of told patient groups about it, and then they've gone back to the clinician and said, would really like to engage with you using digital. A really good example is an orthopaedic patient using their digitally held record for pre-op self-care, and that increased their compliance, helped to manage risk and reduce clinical time. For example, they were aware that their blood pressure was sort of borderline, whether it was going to be okay on the day, if you like, and thinking about white coat hypertension, they recorded their blood pressure for a week before the operation, in case when they went on the day and it was sky high, which could be put, and then they got the evidence to say, well, look, I've been monitoring it all week and it's been fine, but I've walked in the hospital door and it's gone, to support decision making with the clinician. Also, because the length of stay in hospitals is so short these days for orthopedics, the patient having all that information in one place and being able to communicate with their clinician remotely if they've got any problems, found it really good. So it was very much time saving for the clinicians in terms of chasing things up and making sure patients are doing what they should be doing, but also preparation of the patient, making sure their operation wasn't cancelled, and making sure they've got enough information all in that one place, like our strategy identified. It's all in one place, and they know exactly what they're doing. They've got a clear care plan. Also, with just as I was leaving my post, we were looking at delivering digital prehab at the point of GP referral. So anybody who was requiring a referral to mental health services or for surgery, the GP would enable them to start filling in documentation in their digitally held records, so that by the time they get to mental health or secondary care, there's lots of information that's been collected by the patient, and they're there to have a meaningful conversation with clinicians. The last thing I just wanted to say is about reducing hospital stays, because we particularly during COVID, they really didn't want patients in hospital any longer than they needed to be. So the utilisation of the digital health record, give the patient the care plan, they know what they're doing, and they can put their their vital signs in or whatever, pain scores, and then they could be cared for remotely.
So it sounds like there's real pockets of excellence and great positive examples that is about identifying, confirming the benefits and outcomes that it enables in terms of experience and clinical outcomes, and then thinking about how can those be introduced more widely.
Yes,
exactly. And I really like the framing about asking the patient to ask the clinician rather than automatically the other way around, which is typically I think isn't such good.
And we're really lucky because as part of our strategy and our structure, we have a patient advisory group, and everything goes to them before it goes to the to the board. So we've got their opinions and their challenges before it gets to board.
Okay, that's really useful. That, and so that leads on to the next question, really, which I'm going to direct to Karen and to Nick. And this is really around how we support the delivery of user-centered design. So for me, Karen and I have worked. This is work where there's been expert by experience, have been heavily involved in co-designing, co-producing. Nick, you touched on, I think, in the first answer about accessibility and making sure. So, Nick, do you want to just share a couple more thoughts on that? And I'm mindful of the time, so I'm just going to ask for a couple of sentences from each of you on that.
Yeah, so UX design is not a core 1010 deliverable, but in terms of our experience of what good looks like for accessibility, absolutely that is, and we can assist with the designing in for accessibility. It's an unhappy, unfortunate experience of mine over the years is that whether this be in healthcare or in private industry, that accessibility is sometimes a little bit of an afterthought. A system is designed and there's like, okay, well, now how do we make this accessible, rather than how do we make it accessible from the ground up, because it needs a different set of behaviours from your development and delivery teams to make it as accessible as it could be. Can we help with that? 100% we can. Yeah, absolutely.
Great, thanks, Nick. Karen, thoughts from you?
Yeah, just quickly, I think the whole user-centered design approach is about an iterative design process, which focuses on all of the users. Sometimes we forget some, as Nick has alluded to, but the example would be, whilst we bring clinicians into service development, whilst we bring experts by experience on patients and carers, who do we miss out? Who do we miss out in the process? What do the admin infrastructure of an organisation have to say about the processes? And potentially there are opportunities and advice that they have to give as part of the process too. So it's about researching all parts of the process journey and making sure that we have that we deliver something which makes the whole process as productive as possible.
Yeah.
So that's really just from my perspective.
Yeah, it's quite interesting that there's examples, for example, with robotic process automation, which is not user-centered design at all, but it is aligned to what Karen was just saying there about what do back office teams need, how can they be more efficient. There's an example, I believe, from East Lancashire NHS where RPA has saved something in the region of 83,000 paper referrals and things for appointments, and that saves 2.5 people's worth of admin time. There are benefits all over from thinking about it from different perspectives, rather than just from I'm a clinician or I'm a patient.
Yeah, that's a good point, isn't it? And I think just to add to that, my experience of doing sessions where I've done some emotional mapping. So rather than process, it's about how do people feel as they go through this, whether it's an outpatient appointment or whatever, it doesn't matter. But actually, it gives you a completely different lens that you see things through, and then you can round out what's happening.
Yep.
Okay, good.
Phil, can I just add one more thing to that question, and that's around health literacy. So if we're asking patients to use the digital offer, we need to make sure that the way things are designed and the content are, they're able to interact with it and they understand it. And we've built into our project setup collaborative working with the Patient Information Forum, and that's helped us to ensure that patients, they've got the right structure, they've got the right content, it's been co-designed with them, and it takes account of health literacy best practice guidance. And I can really strongly recommend working with the Patient Information Forum, which is a charity, and they have, they helped us. Once I'd written our strategy, which we thought it was really quite well written, we asked them to look at it, and they completely rewrote it for us, because like they challenged us and said, if this is a patient-facing digital services strategy, it needs to be understood by the patients and citizens, and they did a fabulous job at helping us with that. And through that process, as a team, we learned so much.
That's a really good recommendation, isn't it? And it's surprising, isn't it, that how easily we can plough forward without recognising that expert input we can get. Okay, so I've got question 5. I'm going to direct this to each of you in turn and just give you one sentence in effect. What's your response to this? So how can we help you with the people and the skills gap you may have to deliver the things that we've talked about on this call? Nick, I'll come to you. I'm just going to work clockwise around the screen. So Nick, just give us a sentence on what 1010 can offer in support of the broad themes we've talked about today.
Yeah, so the main offer here is our in-house academy. We've been running it for 10 years, and we recruit talented people and turn them into extremely competent and talented technologists, so that to address the technology gap. It's well understood in industry at the moment that there is a technical skills gap. 1010 absolutely can. It's been part of our core business for some time, and that's how we will how we can support ICS providers in that space.
Great. Thanks, Nick. Karen.
Okay, so put very simply, what our offer is that we'll work with you to map against your project scope the capability requirement that you have to deliver a project. We'll find that capability. We'll assign that capability. We'll set the project up, and we'll start to deliver. And what that means for you, sorry, I'm going into 2 sentences. What that means for you is that you have flexibility around the capability that's available. It provides a cost-effective and a cost-efficient solution, because if you don't use the days that you've actually procured, then those can be sort of banked for a future piece of work. And the other thing is that it avoids you having to go out to recruitment for a number of different skills, which generally are done over on a fixed term basis. So it's rapid, it's based around the specific need, and it's flexible.
Perfect. Thanks, Karen. Jane, I'm going to say, I'm not going to answer this on your behalf, but I'm going to suggest that the examples you've shared, I think the innovative and impactful examples that you shared, be great if you're able to share them with the wider group, and that for me feels that that's a great resource that we'd love to continue tapping into collectively on this call, in terms of being able to support the system that's under such huge pressure, as we know.
Absolutely, yes.
Great, thank you. Okay, I'm going to suggest we stop there. I'd like to thank the panelists, so Nick, Karen and Jane, and thanks to everyone who's made time to attend the session. Hope you found it useful. We'll be in touch with some of the details we've shared today, and hope they can contribute to your activity in the future. So from me, thanks very much.
Thank you.